Thank you, Honorable Speaker and members. Honorable Speaker, the first question, and Honorable Speaker, I provided the answers to the members. The first question the member has asked was the implementation of the Social Health Insurance Fund and the analysis of its progress to achieving UHC in the country. Honorable Speaker, the Social Health Insurance Act of 2023, through this House, established 3 statutory funds under the Social Health Authority. And that is the Social Health Insurance Fund, SHIF, the Primary Health Care Fund, and the Emergency Chronic and Critical Illness Fund. These funds form the legal and the operational foundation for the implementation of universal health coverage in Kenya. Honorable Speaker, I have provided the progress of UHC as of 3rd of November 2025. In terms of registration, 27,246,830 Kenyans have successfully registered under the Social Health Authority as of 3rd of November 2025, and that is more than half our population. 2, 81.3 billion shillings have been collected in contribution since SHA began in October of 2024. Service access. How many facilities are contracted by SHA, both public, private, and faith-based? In our country, 10,540 facilities are contracted by SHA. How many patients have we served? 7.7 million Kenyans have accessed services through both the Primary Health Care Fund, which is free for all Kenyans, and the Social Health Insurance Fund, which is at the contracted facilities. And Honorable Speaker, I've given a table for both the PHC Fund, the SHIF Fund, and the ECCIF Fund. And all these funds, for example, the Primary Health Care Fund, which is supposed to strengthen both our preventive and promotive care, outpatient, and optical service, and which is free outpatient to all our citizens. All that they need to do is to register as SHA members, has disbursed 9.8 billion shillings to date. For the Social Health Insurance Fund, that provides very comprehensive coverage for inpatient care, surgical procedures, specialized imaging, renal care, maternity and child health, mental wellness, and cancer treatment, has disbursed 64 billion shillings to date. And for the Emergency Chronic and Critical Illness Fund, which supports the critical care, the oncology service for those who exhaust their shift limits, and accident and emergency, has disbursed close to 1.75 billion shillings. Honorable Speaker, the second question was to provide a report on cancer benefit, which is provided by SHA under the Social Health Insurance Fund. And Honorable Speaker, SHA oncology cover is very comprehensive. And this is where cancer falls. And what does SHA do? They provide support throughout the patient's history, starting from diagnostic all the way to the staging services, to treatment, and even to palliative care. Once you are diagnosed, patients have access to a range of treatment options, including surgery, chemotherapy, radiotherapy, hormonal therapy, immunotherapy, and this ensures that care is tailored to individual clinical needs. The cover also caters for essential medical supplies and equipment, such as consumables, stoma appliances, chemo pumps, and other medication which are used before and after treatment of cancer. Chemotherapy is one of the areas that we have very much focused on. But under the Social Health Authority, significant improvements have been made to enhance equity, flexibility, and comprehensive coverage. And the scope of oncology service covered, Honorable Speaker, I have provided from diagnostic in terms of the numbers. For example, it covers confirmation of cancer type. For first to find out what type of cancer it is and the stage through a diagnostic service, it is covered. And these include the histology and all the bone marrow procedures to find out the PET scans and the numbers. For example, PET scans, SHA pays 53,500. So all the stages of diagnostic and staging is covered by SHA. Then you come to the treatment of cancer. And this covers the chemotherapy administration at 5,500 per administration, the medication up to 400,000, and all the other types, whether it is radiotherapy, hormonal therapy, and immunotherapy. Then the last one is surgical. Cancer patients sometimes require surgical procedures. And all in the document I provided to the House, from prostate cancer to mastectomy for breast cancer, all of them are covered under the Social Health Authority from 134,000 to 168,000 to 50,000 of different. And then lastly is when now we have to deal with the critical and the palliative care of cancer patients. Patients admitted can access critical care services. For example, 28,000 per day for up to 12 days if they're in ICU, and the palliative service care during the inpatient. Honorable Speaker, as a ministry working with the Social Health Authority, we have removed completely the limitation on the number of treatment cycles for cancer patients. We are allowing patients to receive all medical necessary sessions within their annual limit. And finally, Honorable Speaker, the member has asked the facilities which are cancer related and the services they offer. Honorable Speaker, I want to confirm to the House that SHA has contracted 140 healthcare facilities nationwide, both in private, public, and faith-based, to deliver comprehensive cancer care services. A total of 33,101 patients have received care under the SHA oncology package since the establishment of the Social Health Insurance Fund. SHA, Honorable Speaker, has also paid out a total of 5.8 billion in cancer-related claims, with an additional 774 million, which is currently under process, that will be paid by the 14th of this month. So, Honorable Speaker, I want to confirm and commit that SHA remains committed to a timely settlement schedule and robust claim adjudication process to avoid the accumulation of further debts. The fourth question, Honorable Speaker, was to explain the measures put in place by the ministry to review and enhance cancer package, including the steps taken to ensure adequate financing and allocation of funds so as to guarantee equitable access. Honorable Speaker, the Ministry of Health is committed, and the government and the ministry is committed to progressively enhance the cancer benefit package under the SHIF. And what are we doing? Under the established benefits package and tariff advisory panel mandated by the SHA Act passed by this House of 2023, we have asked them to design and review the benefit package every 2 years, but particularly for the cancer patients, we have directed them to review the existing package limits, and our goal is to progressively enhance the oncology package limit to Kenya shillings 1 million per beneficiary from the current 550,000, which still, if a patient exhaust that limit, then they can still use the emergency, chronic, and critical fund which has been established by the House. So the cancer benefits will be jointly financed by the Social Health Insurance Fund, SHIF, annual limit of 400,000, and the emergency, chronic, and critical illness additional 150, providing a total of 550 per beneficiary. But we have, Mr. Speaker, and this is good news, we have negotiated with the private partners, multinationals that are involved in the manufacture of consumables, drugs for cancer patients. And we have signed an MOU with Roche Pharmaceuticals that manufacture a drug called herceptin for breast cancer. In order to lower the cost of that essential cancer medicine. And they have agreed, and we have put it to an MOU, where before I came to the ministry, that drug was costing 120,000 per session. Today, I'm happy to report it is costing 40,000 coming down. And this is to ensure that healthcare is affordable and accessible. Thank you, Honorable Speaker.
If you are satisfied, we move on.
Thank you. I think I have quite a number of questions.
Yes.
Maybe I continue. I'll note so that I can ask at the end of the third question. Thank you, Honorable Speaker. Could the Cabinet Secretary provide a report on the status of healthcare services in Kiambu County, given the doctor strike which has continued for several months, with reports indicating the vulnerable patient, including newborns, have been the most affected? Outline the steps taken by the ministry in collaboration with the county government of Kiambu, to resolve the ongoing strikes, which has resulted in a strain on Kenyatta National Hospital as it is handling more than twice its normal capacity. Provide statistical data on the number of maternal and newborn deaths recorded in hospitals within Kiambu County, particularly between June and September 2025. Explain the reasons for the withdrawal and redeployment of medical interns who had been posted to various hospitals within Kiambu County.
Minister.
Honorable Speaker and honorable members, the first question on the status of healthcare service in Kiambu County. My answer is this. A joint inspection by the Ministry of Health, the Kenya Medical Practitioner and Dentist Council, and other regulatory bodies within our ministry has found out that the service workload, outpatient department visits at facilities like Thika Level 5, Kiambu County Referral Hospital have significantly reduced compared to the same period in the previous year, indicating a strain of service. And I have shared a table comparing between 2024 and 2025 in terms of visits. And Honorable Speaker, if you allow me, in June of 2024, 26,010 have visited hospitals in Kiambu County. Compared to the same period in 2025 during the strike in June, only 17,772 have visited, showing a drop of 31.7%. July of 2024, there were 27,000 who visited, but July of 2025 during the strike, there were only 18,477, another 33.1% drop. And then August was 26,000, August of 2024, it was 26,819, and same time, August of 2025, it was 18,033, a drop of 32. In total of those 3 months, in 2024, 80,452 people visited Kiambu Level 5 hospitals. But in 2025, that dropped to 54,000. So there were 26,000 citizens of Kiambu County who never accessed health facility in Kiambu county. Maybe they were going to the neighboring counties, Murang'a, Nairobi, Kenyatta Hospital, and I would say how that has affected our referral system. The second question was the steps we have taken. Honorable Speaker, and I have evidence to provide. The industrial action in Kiambu arose from a labor dispute between the county government of Kiambu, which was the employer, and its unionist employees under the Kenya Medical Practitioners and Dentists Council, which has strained again our referral hospital Kenyatta, as it was handling more than twice its normal capacity because of the strike. Honorable Speaker, our intervention as a ministry, I have formally engaged the governor of Kiambu by phone, by text, and I have written letters which I have attached for the House to use for reference, urging for a prompt, good faith resolution in the public interest to avert further service disruption. Honorable Speaker, how far I can go is limited. I've been limited by the Constitution since provision of health service is devolved. But now I want to report that the National Return to Work Formula Framework has been signed between the union and the government, county government of Kiambu. My advice is that they should borrow a leaf from what we do in other counties, Lamu, Kakamega, many other counties which had resolved their disputes. And even with the national government, Honorable Speaker, where the national government allocated 1.75 billion in the financial year 2025 through the House to clear the long outstanding medical arrears and reaffirm their commitment to implementing. But the industrial action in Kiambu County has now been resolved. The third question was for me to provide statistic data on the number of maternal and newborn deaths recorded in hospitals within Kiambu County, particularly between June and September when the strike was on. Honorable Speaker, first I want to convey the ministry's deepest regret and the country's deepest regret for the loss of life during the period in question. Any maternal or newborn death is one death too many. And I really want to ask the House that our maternal mortality and child mortality in our country is not good. We are having discussion with our county governments. We will bring a report to the Committee of the Health of this House. I think it's something that we must discuss, that no mother who is not a patient, who is walking to a health facility to give us a living, dies and the child dies. That I think is unacceptable. But coming back to Kiambu County, maternal and newborn services are highly sensitive to disruption in service delivery. So when there's a strike of healthcare workers, the maternal and newborn services are highly affected more than the other sectors. So during the month of June and September, during the industrial action in Kiambu County, significant service disruption routine was reported to us through the Kenya Health Information System. And some staff failed to submit reports altogether. Some staff of Kiambu County. Mr. Speaker, this is a very serious offense. And going forward, we will ask digitally through our digital health agency and our digital system, every health facility in our country will report on a daily basis any maternal or child mortality that happens in that facility. But for Kiambu, it is very, very sad, Mr. Speaker, when staff fail to submit reports altogether, resulting to gross underreporting. Some of them are not reporting the right data of both maternal and newborn deaths. Notwithstanding these gaps, the county government of Kiambu itself have reported 164 newborn deaths over this period. It is very sad, it's unacceptable, it's immoral, it should not happen in any hospital, private, public, faith-based, it should not happen. So 164 newborns deaths were recorded during this period of the strike. Further, in the same period, 14 maternal deaths, 14 mothers died, were reported. And this House should know that because of the reporting disruption, these figures might be grossly understated the true burden. And I want to now read the law for which this House has passed, that failure to report health data or to misreport is an offense under Section 59 of the Digital Health Act of 2023, Honorable Speaker, that this House has passed. And this offense include relating to non-submission, falsification, or obstruction of a required health information. So I am sure colleagues, healthcare workers who get licensed through our ministry from Kiambu County, I want them and the leadership, they must be cognizant of the Section 59 of the Digital Health Act of 2023. And the ministry therefore proposes and will support punitive measures against any officer found culpable for non-reporting or misreporting in accordance with the Act passed by Parliament and all other applicable public service regulations. The reasons why we withdrew and redeployed the medical officer interns who had been posted to various hospitals within Kiambu County. Mr. Speaker and honorable members, I want to report Kiambu County received, because of the number of level 5s and the health facilities and the population, received the highest number of interns. The withdrawal and the deployment of medical officer interns, amongst other healthcare interns, was necessary due to the industrial action in Kiambu County. These interns, by law, must obtain interim practice license that is strictly conditional, and the condition is they must be supervised by qualified and licensed medical consultants. And this industrial action resulted in the absence of crucial supervisory support, meaning that the internship training standards could not be met by these interns. They could not receive it in Kiambu County. And to avoid further delay in the commencement of the internship program, the ministry, under my signature, wrote a letter to the governor of Kiambu, urging the governor to resolve the industrial action by the 15th of September to allow the internship and the interns to proceed. When the industrial action persisted past the deadline, the ministry had no option. We had to withdraw the interns with the effect from September 29 for redistribution to other counties where internship programs was going on smoothly and in accordance with the law. So as much as we wrote to the governor and he did not enter the industrial action, we are the ones who pay interns. We, the ministry, are the ones who supervise, and we pay them through money allocated by this House. And they are Kenyans, and they have a stipulated time frame of 1 year. So, Honorable Speaker, we had no choice but to withdraw so that our interns can continue with the internship program in the other counties where internship program was proceeding smoothly. Thank you, Mr. Speaker.
Thank you, Honorable Speaker. I think I have two questions on top of what the CS has asked. And my first was on my first question, whereby, Honorable CS, you say that we have corrected 80.3 billion shillings as far as SHA is concerned. My question is, out of 81.3 billion shillings, how many have been claimed by the health facilities so far? And can you be able to substantiate, to differentiate between how much go to the public hospitals and how much has gone to the private hospitals? Because, Mr. Speaker, we run a risk of making sure that we correct this money from the public, but at the end of the day, because of the log, and because health is devolved, and because of the log governors who are not able to facilitate, or who are not able to fund, who are not able to make sure that the health facility are in good conditions, many people are going to private hospitals. And therefore, this money may tend to benefit more the private hospitals more than the public hospitals. And the decision that we made as far as the SHA was concerned is to make sure that we improve our public hospitals as far as that's concerned. Mr. Speaker, I also want to ask the CS Duale, you know, the health is devolved, and we want to agree with him, but where can the minister get a grip? Because at the end of the day, when there is that discrepancy, when there is that problem between the county government and probably the health practitioners, what the ministry cannot just sit down and watch people dying. The ministry cannot just sit down and watch health facilities get dilapidated. There must be something that the minister is able to do to call either the governor to order and to make sure that the health services are directed or they are given to the public. Because at the end of the day, even if health is devolved, the ministry has a responsibility to make sure that they provide health to the people of this country, Mr. Speaker. So therefore, can we also plead with the CS, because now the majority of the interns, the interns were taken away from the Kiambu County, and not because now the doctors are back to work. Is it possible, Bona CS? Because if you don't bring these interns to our hospitals, many of our people are now not going to be benefiting actually from the services led probably by these interns, Bona Speaker.
Waziri.
Honorable Speaker, let me start with the second question on what the minister can do. I think all that I can do is administrative, which I have done. Health is devolved. The legislature has the powers of oversight. I have contacted the health committee of the Senate, the health committee of this house, are aware, and it is the decision of the Kenyan people who have devolved. If today healthcare workers go on industrial action in our referral hospitals, which are under me, then I will. But all that I can do is to do administrative, write letters, consult with the Council of Governors, which I did, talk to the governor, and I think that I have done. On the matter of withdrawal of the interns, interns is a very important component on the training of our medical and healthcare workers in all cadre, whether they are doctors, medical officers, whether they are dentists, pharmacists, clinicians, nurses, and they have a period to do internship. We have already disrupted them when there was an industrial action in Kiambu. I think it would be morally wrong for me to provide and tell them again, go back to Kiambu. That's another disruption. So the next time I'm going to post, particularly medical interns, pharmacists, dentists, clinicians, and many of them, in my opinion, will be next year when I'll do the next cohort. In terms of how much we have paid, but before even I come to how much we have paid, I think under the Social Health Authority Act, there's no discrimination. Kenyans can access, if they are members, Social Health Insurance Fund. They have all the rights to access it, either faith-based, private, or public. And that was the whole essence of UHC, for health services to be accessible, affordable, and equitable. And that's why we are saying that if a Kenyan works, even for primary health care, which is free, if he walks to the nearest facility, be it private or faith-based, he should get exactly the same treatment as that he could have got it. 2, how much we have paid in terms of the 3 different levels. For the county governments, we have paid about 23.2% of the total 64 under chief, we've paid 64 billion. So 23.2% went to county government or public facilities run by our counties. Faith-based facilities receive about 16.87%, and the referrals receive about referrals that are Kenyatta National Hospital, Moi Teaching, Madare Teaching and Referral Hospital, Jaramogi, and Mwai Kibaki, Odaya. They have received about 10% of that share. And the private had the largest with 49.07%. This payout is driven by a number of factors, Honorable Speaker and members. One is the service utilization. How many services are available in all those 4 categories? 2, the type of procedures offered by those facilities. Inpatient, maternity, surgery, oncology, dialysis. The more a facility has those different types, the more they get more paid. And then Kenyans have a choice on the type of facility to access. So if they're in Nyeri County, for example, they have a choice to access either to Mutumu, which is a faith-based, or to access Consolata, which is a faith-based, or to access the Nyeri County Referral Hospital Level 5. Claim processing capacity and claims desk available are in all these facilities, whether it's private and whether it is in public or faith-based. When I come to now the primary health care payout, which is free, and this is now where, Mheshimiwa, I think your question fits well, where Kenyans walk in and walk out as outpatients. They are treated, they see a medic, they get drugs, they get lab tests, they can get the basics, but it's an outpatient. And all that they need to do is to register as SHA members, not chief, as SHA members. In the PHC, which I gave the figure of the 9.8 billion has been disbursed, county governments have received 56% of that 9.6 billion. The faith-based facilities in the public health facility, which is free, which is paid by the exchequer, have received 7% of the 9.8 billion. And the private facilities across our country have received 36% of this 9.8 billion that was paid out to all facilities that offered service under the PHC.
Thank you, Minister. Member for Nyandarua, Faith Gitau.
Thank you, Honorable Speaker. Could the Cabinet Secretary provide a report on the measures the ministry has put in place to avert a potential tuberculosis crisis, as many patients are resistant to its drugs for treatment, including ensuring timely access to prevention, testing, and treatment services? Question number 2, outline the actions being taken by the ministry to secure affordable treatment for multi-drug resistant tuberculosis, considering its more challenging and prolonged treatment regimen. Number 3, state the efforts in place to preserve and build upon the progress previously achieved in the fight against tuberculosis through USAID funding. Thank you, Honorable Speaker.
Waziri.
Honorable Speaker, the member for Nyandarua County, Honorable Faith Gitau, asked 3 questions. The answer to the first one on where the ministry has put in, what are the ministry measures put in place to avert a potential tuberculosis crisis as many patients are resistant? The answer is that Kenya, as a country, we have made a very commendable progress, Honorable Speaker, in the fight against TB. And why do I say so? We have achieved a 41% reduction in TB incidents and 65% reduction in mortality towards the 2025 TB strategy milestone. So that 65 reduction is that there are very few people now who are dying because of TB closes in our country. And this is commendable. But there's a burden of this, the burden of the drug resistance TB, particularly the DRTB, has also dropped by 48% since 2015. And this has led to WHO, the World Health Organization, to remove Kenya from the list of countries with high burden of DRTB in the year 2020. So our achievement, our efforts as a country in the fight against TB and TB-resistant drugs has borne fruits, and WHO has even removed us as a country from that list in 2020. What are we doing? What measures are we doing to avert TB, the DRTB crisis? Number one, we as a ministry, we are strengthening the diagnostic capacity. We have expanded the molecular testing using the 2027 Gene Expert, the 2028 LAMP, and 78 TrueNet platform across all our 47 counties. And I did this a number of times. The last time I did was about 1 month ago. And again, we are doing genome sequencing, which has been introduced for DRTB surveillance. So we do surveillance using technology. Two, we have also enhanced, Honorable Speaker, the treatment for DRTB. The treatment has evolved from 24-month-long regimens to the current 6 to 9 months regimes recommended by WHO. So treatment now is offered free of charge in all public government facilities. So that's how we can enhance and reach as many of our citizens. Three, we have done decentralization. The treatment now has been decentralized to 900 primary healthcare settings out of the 5,400 facilities offering TB treatment nationally. And this is to ensure continuity of care and improve patient support. So within the 5,400 facilities, we have decentralized 9 of them as a primary healthcare. Then we also build the capacity of our healthcare workers. The ministry has developed a national DRTB guidelines. We provide continuous training and mentorship to equip healthcare workers with updated skills in diagnosis, in clinical management, and particularly in the infectious control of TB. We have done community engagement and patient support to support patients to complete treatment, because if you don't complete treatment, that's when you have a problem. So we make sure that we do community engagement, we provide patient support so that our citizens who are patients suffering from TB, first they complete the treatment and prevent DRTB. This intervention offers, we do a lot of counseling, we talk to them about their nutrition, we talk to them about their transport support, while the community health promoters that we have over 107,000 across the country in every village help us do a follow-up. They do contact tracing, and they also do psychological care at home. And finally, we have enhanced the DRTB surveillance. We conduct very regular cohort reviews just to make sure and to track the DRTB performance and see if there will be any gaps or challenges that we can address. So a national drug resistance survey is currently underway to make a determination, and Honorable Speaker and members, once the survey is ready and is launched, just like last week I've shared a number of reports with the House for tabling, we will table so that we get, this survey will give us the true DRTB burden in our country. Honorable Speaker, the other question was to outline the action being taken by the ministry to secure affordable treatment for these multi-drug-resistant TB clauses, considering the more challenging. And Honorable Speaker, the ministry and our partners will always focus on ensuring that there's consistent, there's adequate, there's affordable supply of the drug, that is the DRTB medicines. Secondly, we do what we call accurate quantification. The National TB Program conducts regular quantification exercise in order to, and they use up-to-date patient data and electronic Queen TB tool so that we can accurately forecast the DRTB medicine needs of our country, and that will help us to prevent any shortage or stockouts. The supply chain management, we are working with the KEMSA to efficiently manage procurement and distribution, including the use of the Integrated Logistic Management and Information System for real-time tracking and for last-mile distribution. Now we have a turnaround of about 7 days, and national buffer stock is maintained, Honorable Speaker and members, to cushion against any delay in case of any disruption in the global supply chain. Lastly is our procurement strategy. Honorable Speaker and members, up to 70% of the treatment commodities for drug-sensitive TB are procured using GOK funding, which will help us to enhance sustainability and reduce reliance on external sources. So on TB, we have 70% to make sure that none of our citizens miss out on these important drugs. The last one, Honorable Speaker, was to state the efforts in place to preserve and build upon the progress previously achieved in the fight against TB clauses through USAID funding. Honorable Speaker, we have initiated a deliberate measure to safeguard and scale the gains achieved through USAID support and aligning them with the national UHC agenda. We have done health system integration. TB services now are being integrated into primary health care and UHC framework to ensure sustainability and reduce dependence on vertical programs. So Kenyans now can visit their level 2, level 3, their dispensaries, their health centers to access these TB services. We're also building the capacity continuously, training of our community health promoters. We are training our clinicians and lab staff in order to maintain a thorough on-the-job mentorship, and government supports these fresher training programs. And lastly, we do domestic financing advocacy. We continue as a ministry to advocate for increased domestic financing at both national and county level. The annual TB budget for the financial year, Honorable Speaker, 2024-2025 was $136 million, of which government funding covered only 1% and donor funding 20%, leaving a 79% funding gap. We will appeal to the House, the National Assembly, which is a budget-making house, for increased resource allocation. But, Mr. Speaker, I don't want to say much, but we are talking to our colleagues under the new U.S. administration, and we are coming up with a substitute for USAID. And I think by the end of this month, the country will hear the good news. That we might not call it USAID, we might call it something else, but we are negotiating, and by the end of this month or early next month, we will find a way of how we can bring back the role USAID played, because USAID was key in this area. And then, of course, we are collaborating at the multi-sectoral level to make sure that there's accountability. And so sectors like housing, nutrition, correctional services, and labor, we are also telling them how to address the social determinants of TB. Thank you, Honorable Speaker. But just to finish, we will, through Honorable Gitau, and we will write to the House, we will ask for more allocations. But rest be assured that TB control will closely linked to poverty, it's closely linked to poor housing, it's closely linked to poor nutrition, and that's why we have to adopt a multi-sectoral approach and talk to other stakeholders for accountability framework. Thank you, Mr. Speaker.
Faith Gitau, you're satisfied?
Thank you, Honorable Speaker. I want to confirm to the Minister that we have no TB drugs in Nyandarua, and most of the hospitals around, in Kenya, do not have these drugs. Please, you have said that you're providing free of charge. When do we expect these drugs in our hospitals?
Minister.
Honorable Speaker, I was in Nyandarua 3 weeks ago. I want to confirm to the House there are plenty of TB drugs in Nyandarua. And I am ready to send my officers to Nyandarua with the Honorable Member to go and verify. I am ready, Honorable Speaker. I cannot lie to this House. The TB drugs are available in Nyandarua County, in all the hospitals, and I'm ready, under your direction, that the Director General of Health, approved by this House, is here. I will dispatch him to Nyandarua tomorrow and to confirm to the Honorable Member.
Fair enough. Kagusha.
Thank you, Honorable Speaker. Could the Cabinet Secretary in charge of health clarify whether there is an outstanding debt amounting to Kenya shillings 450 million shillings owed to Consolata Hospital, Mathari, and of course 433 million to Nyeri County hospitals, including 36.7 million for Mukurweini Hospital and 236 million for Tumutumu hospitals.
That is
and this comprising
order, Kagusha. That's not your question. You are not allowed to go beyond what is on the order paper. So just read out your question. You can ask those other figures in your supplementary.
Thank you, Honorable Speaker. And this amount comprising of arrears accumulated at the National Hospital Insurance Fund and payments for the Social Health Authority, that is NHIF and SHA. Number two, state the factors contributing to the prolonged delay in remitting payments to Consolata Hospital Mathari, despite the provision of health services to patients. Of course, Honorable Speaker, I would like just to note that the fraudulent payments in millions have also been made to dysgenius hospitals, while genuine ones are missing out. Honorable Speaker, number three, outline the measures put in place to ensure the debt owed to the hospital is promptly settled and its operations fully restored. Number four, provide a timeline for the payment of the arrears and dues accumulated from October 2024 to April 2025 to Consolata Hospital, Mathari, by SHA. Thank you, Honorable Speaker.
Minister.
Honorable Speaker, on Consolata Hospital, Mathari, I first want to clarify that the NHIF legacy debt, and that is one of the problems, biggest problem that we are facing as a country, and which is making the implementation of the Social Health Authority a bit bumpy, because many of the questions that are raised on debt are on the legacy debt of NHIF. As of 30th September 2024, when this House enacted the new Social Health Authority Act, the NHIF liability owed to Consolata Mathari Hospital stood at 153 million. This facility falls under the category of health providers owed amount exceeding 10 million shillings and is subject to verification and validation process as mandated both by law by the Constitution, by the PFM Act, and by the presidential directive prior to any payment being made. So, Honorable Speaker, and I've attached the letter that Kenyans who are owed between 1 shilling to 10 million of the former NHIF debt, amounting to 5.3 billion, accounting for 92-93%, will be settled. And I've written to the Minister for National Treasury, and I'll table the letter, that he puts it in the supplementary estimates. And currently, Honorable Speaker, using the audit, pending verification audit led by the former Auditor General and the leadership of Social Health Authority, we are auditing and we are verifying and validating all the pending bills of NHIF. On SHA payment status for consolata and outstanding payment, the overall SHA settlement rate for all our faith-based organization facilities, whose their bills and invoices and claims have been verified, reviewed, clinically checked, and are ready for payment and paid, is standing at 65% as of today. Consolata Hospital Mathari will receive 29,324,966.47 for claims which are currently being processed by SHA. They have been validated, they have been reviewed, and they have been confirmed that they are the right claims, and they will be paid in the next payment cycle, which is the 14th of November next week. Honorable Speaker, I have also provided a table summarizing the payment status of Consolata Hospital Mathari. And this is a document. Since SHA started, Honorable Speaker, over 372 million have been paid to Consolata Hospital Mathari. And that constitutes about 17,432 claims. In October of this last month, we have received 4,792 claims, totaling 81 million. And they are the ones which are under review. Honorable Speaker, it's good to say it here on the floor. And the leadership of Consolata, we have told them, we have shared with them, they said with the claims managers at SHA, a total of 335 claims have been rejected with a money value of 14,799,325. And Honorable Speaker, if you allow me, what is a rejected claim? A rejected claims is number one, if that claim you have lodged and the patient was Honorable Duale, the Minister for Health, if that claim does not have a claim form, I am sure every member sitting in this house, when you go and see your doctor, there is a claim form that you sign. The first part of that claim form, it is the patient who signs your name, your address. The second part of that claim form is signed by the doctor attending to you. And the last part is signed by the hospital administrator. We have situations where, number one, there's no claim form. Number two, a claim form is written with one biro pen with the same handwriting. That claim is rejected, is fraudulent, and it will never be paid. So Consolata has a rejected claim of 335, totaling 14 million. We have returned claims totaling 15 million. 877, Honorable Speaker. What is return? When certain important documentation are missing. Invoice is not itemized, documents are missing. Those are not rejected. The law allows you to go back, bring those documents missing, and you don't need to bring them physically. You just need them to upload into a digital superhighway. Then sent for payment, which will pay by the 14th, is 29,324,966. Then they have got 127 million, a total of 2,800 claims, which now is under review, and our doctors, clinicians, the system is reviewing. Is everything in order? We don't want to pay unless we make sure. So in total, Consolata is not even the 450. It's 676,205,000, and I've given the order what is due, what is required for documentation, what has been sent for payment, and what is rejected, and what they need to provide. On the factors contributing, Honorable Speaker, to the prolonged delays in, some of them I have said, but let me say the problem with the Consolata, and I hope the Member of Parliament will go on, because we have told them ourselves, the complex claims. Consolata Madari Hospital submits high-value complex claims for service, such as surgery, oncology, dialysis. These high comprehensive medical claims, they require very comprehensive medical review as part of the claims adjudication in order to process to ensure adherence to established clinical, contractual, and financial compliance. They must be subjected to some audit. So if it's oncology, we must make sure the cancer patient was there. He has gone through all the systems. We have to check the ID card. We have to, if it is surgery, we must make sure there's theater notes and all the other. And all this is for compliance because of the contractual obligation, because of financial compliance, or because of standard before payment. And the claims under review are for the period 12th of August to 30th of October. Number two, with the Consolata, we are facing what we call provider submission issues. There's delays, which are largely occasioned by provider-based factors. If they take long to provide submission of documents, if there are missing signatures in those documents, if there are incorrect patient details, and if there are low resubmission rates for correction, then the Social Health Authority will not be blamed. And we are telling all facilities, public, private, and faith-based, including our referral hospital, going forward, they must employ dedicated staff, managers, claim managers, who will make sure from morning to evening they are dealing with claims and reimbursement and work closely with our county and relationship managers for different categories. Honorable Speaker, the last question was, and then we had an issue of, we took long in terms of claims management, but I want to say that because of many litigation and court cases, at least now, SHA has since hired 9 case management officers, and recruitment is going on to build the capacity. The third question, Honorable Speaker, was to outline the measures to put in place to ensure the debt owed to hospitals. I think on the NHIF legacy debt, the claim of Consolata falls above the 10 million threshold, and we have subjected it to comprehensive verification and validation process mandated by the President and the Cabinet. But Honorable Speaker, let me now speak as a Kenyan. I think Parliament at some stage will come and talk to you. I think there are facilities, and they are both in public, private, and faith-based, that face imminent closure because of the NHIF legacy debt. I think we must do whatever it takes, and I will do it myself as the Minister for Health in consultation with the President and the Cabinet to make sure that we resolve this. Because once we resolve that, then I think a lot of the questions are on that legacy debt. On NHIF claim settlement, as I have said, we are reviewing our medical review capacity. We have done full automation of the claims processing using AI-driven in collaboration with the Digital Health Agency, and now we have a faster verification and timely payment. And we have enough money, Honorable Speaker, to pay our facilities. We are doing also stakeholder engagement. I led a meeting with all the bishops who run, and the different churches that run, and the SUPKEM who run faith-based. And we have agreed, we have created individual relationship managers. We have set a number of private sector players in Nairobi and the surrounding counties. When we do our rollout, SHA rollout, we also engage with the people. But I want to ask Honorable Member from Kroini that even tomorrow we will engage with the Consolata Madari Hospital so that we reconcile our accounts, because they provide very important facilities. But Honorable Speaker, if you allow me, I had 2 weeks ago, I had met in Rumuruti the CEO of Tumutumu, the CEO of Chogoria, and the CEO of Kikuyu Eye Hospital. And they sat with our team led by Dr. Masi. They have reconciled the claim submitted by Tumutumu is 276 million. Payment completed is about 137 million. In October payout, they received 14 million. We have a rejection of 21 million for Tumutumu, and we have under review close to about 103. So we are engaging them, and all our PCA hospitals, we are talking to the Secretary General. So on a daily basis, we had the Deputy Secretary General of PCA, and on that occasion, I'm the one, Honorable Karani, Dr. Karani was there. I'm the one who asked, please come with the big hospitals, and we did, and we have reconciled.
Sure.
Thank you very much, Honorable Speaker. May I start by thanking the Cabinet Secretary for having given me students for Mukurweini KMTC. The students have now reported, and they have started learning. And actually, they started learning today. And for that reason, Honorable CS, I want to very sincerely thank you very much on behalf of the people of Mukurweini. Honorable Speaker, it is indeed true what the Cabinet Secretary has raised, that Madari Hospital and Tumutumu Hospital and other faith-based hospitals in Nyeri County faces imminent closure, especially because of what he has called the legacy debt owed by the NHIF. And of course, we also have other private providers in Nyeri County and other counties that have that challenge. Honorable Speaker, the issue of Madari Hospital having claims which are high value, which are quite sophisticated and complicated, is not a surprise, because this hospital offers very good machinery which is advanced and which also is quite sophisticated. And for that reason, there is need to get a working formula with this hospital so that they do not get unnecessary delays in terms of their refunds. Honorable Speaker, one of the issues that is being raised by quite a number of doctors, and I had a chat with a doctor by the name Gudigol from Nyeri County. One of the issues they are raising is some of the requirements by SHA, which are raising ethical and legal issues. When, for example, Honorable Speaker, SHA requires you to provide written notes after every surgery by the doctors. One of the issues which is coming out that this information is quite sensitive, and if this information has to be passed through the what the CS calls the information superhighway, sometimes it's also considered to be an insecure information system. And you can imagine what kind of damage this information would do to the patients if it lands in the wrong hands or if it gets out there in the public. And of course, Honorable Speaker, this also is seen to be against our Data Protection Act. And I think the ministry, SHA and the ministry will actually need to come up with this to come up with a way of handling this information. The last issue, Honorable Speaker, is that in Mathari Hospital, which is handling a lot of oncology issues, they are also missing coverage for a number of cancer treatment and diagnosis procedures, like the biopsies, histopathology, immunohistochemistry, cancer staging CT scans, which are very important in diagnosis of cancer, and of course, which are also pretty expensive. Some of them go up to 40,000 and above. So, Honorable Speaker, there's an issue maybe that we also need to be addressed. Lastly, Honorable Speaker, very lastly, I can see the Honorable Chair for the Health Committee is also here. Honorable Speaker, you remember I raised a question here and a statement request on the issue of blood transfusion reagents and blood bags in the country. Honorable Speaker, now it is well over 7 months or 8 months since I raised this question in this House, and the chairman has not responded even after approaching him privately, personally, severally. Honorable Speaker, maybe you need to prevail upon the chairman of the committee to respond to this very important question, especially now because the CS says that the US is returning their funds, even though through a different name other than USAID. Thank you very much, Honorable Speaker.
Leave the chairman out for now. Chairman, prepare and bring a response next week. Minister?
Mr. Speaker, the Social Health Authority was enacted by this House, and it aligns to the data protection. The same with the Digital Health Agency. And if member from Ukraine, and thank you, you came to my office, I am happy I have complied on the MTC issue. And that's why I want to tell you, this is a government that delivers. When leaders come, despite their political orientation, we serve the people of Kenya. But SHA complies with the Data Protection Act mechanism in place. 2, patient consent is also availed. But let me bring to the attention of this House, Honorable Speaker, that claim adjudication requires verification that the service took place. The doctors who are talking to you, and I'm sure they are watching me, one of the basic, I'm not a doctor, but I sit with the doctors every day in Afia House, and next to me is the Director General of Health, who this House has vetted and approved, and in Section 16 of the Health Act says he is a technical advisor to the minister and government, including parliament. In medical school, in theater, for Social Health Authority to confirm a procedure has taken place, that facility, that doctor must provide theater notes. Minus theater notes, that claim is rejected. I'll give you another more simple example. If a delivery, a maternity delivery has taken place in a facility, whether through C-section or normal delivery, and you want Social Health Authority to pay, part of the claims document, there must be a very important document known as birth notification. If there is no birth notification, then how can SHA pay you and prove that a child has been born? You know, Honorable Speaker and members, we should not compare the Social Health Authority to the defunct, corrupt, with no system NHIF. They are world and world apart. It's like first world to third world. It's like day and night. So the people who used to be paid millions of shillings for birth or maternity without providing birth notification, that will not happen anymore. Without, even Honorable Speaker, now for a doctor to use his authorization, pre-authorization, OTP, he must be within 500 meters of the health facility. There were days when doctors and healthcare workers could could use their OTP to authorize from their bedroom at midnight. We want doctors, when they want to use their pre-authorization code, we want them, and healthcare workers, we want them to go and visit and do it in the health facility, meet the patient, see the condition of the patient. Never again will theaters and health facilities be run using the mobile phone of healthcare workers. Honorable Chair, I don't want to go into the blood services. I have done the answer. The chairman, my chairman, is very capable and competent, and I'm sure when the time comes, he will provide the answer.
Kazi Mtandaza.
Thank you, Honorable Speaker. I rise to ask question 74 of 2025 to the Cabinet Secretary. Could the Cabinet Secretary, 1, provide a report of payments made by the Social Health Insurance Fund, including the number of vulnerable people catered for by chief in Matuga constituency and nationally? 2, state the timelines which the Social Health Authority, SHA, will reconcile payments made under NHIF through the NGCDF that were not transferred to chief, and indicate the fate of these payments. 3, outline measures implemented to cover the patients who are unable to pay their balances after exhausting their chief cover. And 4, state the plans put in place to clear balances of patients detained in public hospitals due to their pending hospital bills balances after exhaustion of their chief cover. Thank you, Honorable Speaker.
Minister.
Honorable Speaker and members, on the vulnerable persons, the national government is currently sponsoring households, translating to about 1.5 million Kenyans who their data was picked from the social protection net across all constituencies and divisions and wards in our country. Of this number, 1,769 households were from Matuga. So the 558,000 indigents that we launched at the national level, we have confirmed and we can provide the list. 1,769 households are from Matuga constituency. And these members are now active and can access all available SHA benefits and paid for by the government of Kenya under the able leadership of President Ruto. Additionally, over 62,461 households are sponsored by counties, the NGCDF in our various constituencies, and various development partners and philanthropists. Question 2 was to state the timeline. Honorable Speaker and honorable members, SHA recognizes that some sponsors, including NGCDF, have had made prepayments under the former NHIF that need to be transitioned to the new Social Health Authority. I really want to ask the indulgence because we didn't have staff, we were recruiting, there were many court cases, but now serious reconciliation of these transitional prepayments made by members of this House to the defunct NHIF, such as those from Matuga, are currently ongoing, and I have directed the leadership and the board of SHA that they must conclude it before Parliament goes on for the long recess, so that members can now identify and use these resources for the indigent among their constituencies. And then SHA has also committed to finalize this transition of these balances and they will credit them to the members' SHA accounts as soon as possible. We will also, Honorable Speaker and members, provide a comprehensive update on such payment once the reconciliation is complete before the House goes on recess for all affected counties and entities. And these prepaid balances will be credited into their accounts. Number 3 and 4, Honorable Speaker, combined was the measures implemented. Honorable Speaker, the Ministry of Health acknowledged the concern regarding patients reportedly detained in public hospitals due to unpaid bills following the exhaustion of their shift cover. What measures are we doing for this, to give these Kenyans financial protection? And before I give these measures, Honorable Speaker, SHA will not pay everything. We are only now dealing with oncology. We want to make sure we increase the package for oncology, and that because cancer is a serious disease in our country, that we protect the most vulnerable cancer patients. But if you go to use your shift card, then you must be ready to pay a balance that will be left after. But we want to expand the benefit package, and this includes the emergency chronic critical illness fund. We want them to cover the very critical and the very prolonged care after you exhaust your shift limits or your shift limits are reached. Then, like cancer, oncology, if the member exhausts, then we will now, the CCIF kicks in, that was found. On another financial protection, we want to look at how we can strengthen mechanism for financial protection, especially for indigents and vulnerable population, through our social health subsidy program. And this subsidy program will be targeting the most vulnerable people of our society. So we will continue to work closely as a ministry with the SHA and our county governments to ensure that financial hardship does not deny citizens access to essential healthcare service. And this is the philosophy behind universal health coverage. Thank you, Honorable Speaker.
Yes, Tandaza.
Thank you, Honorable Speaker. Let me start by saying that I'm half happy, given the statement that they are working on the vulnerable people in Matuga. And he has said, before we go for recess, he'll have completed that process. I'm half happy because I highly doubt if that will be done, considering that when we met the ministry last time, I think in Naivasha during our retreat, that time we were given as parliament that in 4 weeks that process would have been done, and that I think in February. Now we are in November, but the CS says before we go for recess, that means in 2 weeks' time or thereabout, that will be completed. I would want that to be noted and actually see if it will actually happen. If it happens, I'll be full happy. 2, there is a communication which I think should be very clear, CS, through the chair. The information out there is that once you are fully covered by SHA or SHIF, all medical expenses are taken care of. And I think that's what brings the problem of people saying SHA doesn't work, because now the CS is saying it's not designed to cater for everything. I think this information should be very clear, because all the communication that we get from the executive is that once you are covered, go to any hospital, walk in, be treated, and go back home. But here the CS has said it does not cover everything. Can that also be clear and be communicated so that we know the limits of SHA? Thank you, Honorable Speaker.
Minister.
Mr. Speaker and honorable members, I want to make it very clear, and it's even very clear in the laws that this House has passed. What is paid by the exchequer and is free to all Kenyans, as long as they are registered with the Social Health Authority, is the primary health care in level 2, level 3, and some parts of level 4. That one is very clear. The President has made pronouncements. The Honorable Speaker has made those pronouncements. And we should not confuse Kenyans And that's why 9.8 billion has been paid out. Reimbursement for primary health care facilities, both in public, private, and faith-based. Outpatient. You walk in, you walk out. And Honorable Speaker, the governor of Nairobi is one governor I want to thank. In his primary health care facilities, level 2, level 3, and part of sub-county, he has made it put clear even posters saying, walk in, walk out. So that, but we have in some instance where some counties are co-charging. It's called co-paying. And even the committee of this house have gone out and they have found out. And we have said that it's criminal, it is not right. Now we come to SHIF, the Social Health Insurance Fund, where you pay, if you are in the formal sector, salaried people, 2.7% of your income. And if you are in the informal sector, you go through a mean testing and you pay based on what the mean testing tells you, based on your assets. That one, the Social Health Insurance Fund, is not free. You must pay for it. And that's why if it's maternity, normal delivery, 10,000, fully covered. But there are certain specialized. If you overstay in the hospital, maybe the bill is about $1 million, SHIF will pay 700, 600. The balance must be paid by the patient. Honorable Speaker, I want to confirm, when members were being given that commitment in Naivasha, I was not the minister. But I want to confirm, and I know, Honorable Speaker, when you go on record, I was not...
Mr. Speaker, the Honorable Cabinet Secretary has kept on telling us that in some instances, the SHA will pay and it will leave some money for the patient to pay. Is the minister aware? Is the minister aware that the Constitution guarantees Kenyans health services? Because there are some Kenyans who are very poor, and they don't choose which type of sickness that will befall them. Any type of sickness, whether expensive or not expensive, may befall them, and they will overstay in the hospital because of those sicknesses, or it may exhaust their contribution. Why can't the government say where it's exhausted, they pay for the patient? Because it's not his wish and he has no money.
Yes, Bayer.
Thank you, Honorable Speaker. I think the Honorable Cabinet Secretary has been very clear on SHIF, SHA, and the other one. And I think the Honorable Wanjala, the Honorable Wanjala needs to be awake and listen to SHIF or SHA, the one that pays and the one that you don't pay. Those are two different things. So I think Honorable is probably to say SHIF does this and SHA does this, so that the Honorable Wanjala understands clearly.
Naisula. Order.
You are not qualified to answer.
Naisula.
Wanjala, your noise maker. Honorable Speaker, I heard the Cabinet Secretary clearly giving credit to the governor of Nairobi, but then he said there are some counties which are co-charging. It is in the same breath that those counties should be named in this house, because for the same stick you give credit, we need to punish, and those counties have to be ashamed and they have to be named, and those governors should be surcharged and should be jailed for co-charging the patients, Mr. Speaker. They need to be named.
Yes, Jalango.
Thank you so much, Mr. Speaker, and thank you so much, Cabinet Secretary. The one thing that does not come out very well is to what level is SHA or SHIF taken care of. We have situations, and I had a public participation just the other day, where we have patients who SHA have covered large amounts, and those that have been covered in very small amounts. So they keep on wondering. This guy was paid, the patient was paid bill was paid to an extent of 300,000. There's this one who is requesting only 15,000. It is not being paid. So there's one thing that the cabinet secretary and his team must come out and tell the public. Continuous communication about what is covered by what to what extent. And lastly, Mr. Speaker, during this public participation that we had with our people, there are those who still want even to be told to be taken through on how to register, and they want to register, they still don't know how, and your medium of communication cannot rely on TV and newspapers only. Nowadays we have so much. You're even talking about AI being used now in the medical space. We have these influencers. We have these social media spaces that we need to have this communication go out again and again so that we demystify this thing about SHA. It is working, yes, but you get to a point where you still have to explain to people, Mr. Speaker. Cabinet
Speaker,
you made your point.
The cabinet secretary needs to come out, as my colleagues have said, very clear.